Good evening and welcome to Toxicology and Substance Abuse for the Paramedic Provider. So for our purposes today, poisoning is going to be used to describe exposure to non-pharmacological substances, and the term overdose is going to be used to describe exposure to pharmacological substances, whether accidental or intentional. So some background information. We can see here that emergency department visits and EMS responses for poisonings are fairly common, and we see that a lot of them occur in children under the age of 6. This is a fairly common call that we're going to be responding to as EMS providers. So here's another slide of background information. A child who's experienced an accidental ingestion has a 25% chance of another similar ingestion within 1 year. And 80% of suicides involve a drug overdose. I'm sure we've all been on those calls for an accidental child poisoning or a suicide involving drug overdoses. Adult poisonings account for 90% of hospital admissions for toxic substance exposure, and most of those are intentional. So your best resource for finding out information about poison victims is to contact your poison control center. The number is 1-800-222-1222. It's also worth noting that Medical Command has access to a PoisonDex software, and the 911 centers have access to poison control. So however means you choose to get a hold of them, it's best to give them a call when you're responding to these calls, if you can figure out what the substance is that's been ingested, so you can figure out a treatment plan before you arrive on scene. There are 4 routes of entry for toxic exposure. Ingestion, that would be to eat it. Inhalation, so you could inhale it. Surface absorption through the skin, or injection. Toxic substances have both immediate and delayed effects depending on their route of exposure. So for example, if you inject heroin into your vein, that's going to be a much more immediate effect than it would be, say, if you did it IM or you ate it. So ingestion is the most common route. Seems like we're seeing now these kids are wanting to eat the Tide Pods because they're pretty cool colors. We've seen several of those calls lately. Some poisons can remain in the stomach for several hours, and a large bolus of poison can slow down the absorption of that poison. But they can burn the lips, the tongue, the throat, the esophagus. Anything on that route of ingestion can be affected depending on what substance has been ingested. So here we have a list of some common inhaled gases. You can see at the top there nitrous oxide. If you go to the dentist, you can get some laughing gas and inhale some nitrous oxide. CO poisoning is probably one of the more common calls that we go to involving inhaled poisons. In wintertime, people don't properly ventilate their heating system and end up with CO poisoning. And chlorine gas is a very toxic choking agent that, if released, has the potential to be very harmful. Luckily, the transportation industry does a pretty good job of containing that when it's out on the roadway. But if one does roll over and leak some gas, we usually hear about it on the news. So when you inhale a toxic substance, lots of bad things have the potential to happen. It's fairly detrimental to your lung tissues, not only in the short term, but in the long term. So in the short term, the absorption of that toxic agent is very rapid through the alveolar capillary membrane and right into the bloodstream. But in the long term, it can irritate your lung tissue, it can cause atelectasis, COPD, it can even destroy your alveoli, causing very complicated long-term problems. So surface absorption is probably our slowest absorption route for poisons to get into the body. Can be from contact with poisonous plants such as poison ivy. That is a surface absorption of poison. One of the big ones they always talk about when you go through paramedic class is organophosphates. There's case studies and all that about this weird unknown medical call where you get there and the guy is seizing and has teary eyes and all that good jazz. But in reality, organophosphates were outlawed in the United States in 1994. Where we're seeing it now is drug farmers. So if you have your big illegal pot farm out in the desert, you're probably not going to go to the hardware store and buy tons and tons of pesticides to keep your illegal pot farm growing. So what they do is they get organophosphates from Mexico or other places where it's still legal and use it on their pot farms. Injection is going to be our fastest route of toxic exposure. So it goes directly into the skin or into the bloodstream and starts its absorption process immediately. It can cause an allergic or anaphylactic reaction from stings, bites, scratches, whatever, or from marine animals, including jellyfish, or it can be intentionally injected into the skin, like with a heroin overdose. Scene size up is going to be very important for these calls. As we know from earlier slides, 80% of all poison calls involve a suicide attempt. So those patients may have potential for violence. If you're stopping them from hurting themselves, they may end up wanting to hurt you in the process. They may often be intoxicated by whatever they have ingested. And you also need to look for signs of chemicals or hazards. Anytime there's multiple patients involved, whatever has made those 2 patients or 3 patients sick could probably make you sick as well. So anytime there's any kind of poison involved, the hazard to you increases because you don't want to become part of the emergency. Primary assessment is going to be about the same as with every other patient. You want to quickly assess their mental status and figure out their ABCs. A lot of the times with inhaled poisons, airway problems are going to be prevalent, pulmonary injury, airway injury, increased secretions, or decreased respiratory effort. So airway management is going to be key for managing these. Secondary assessment for these responsive patients, you want to see if you can get a pill count or ID the substance, whatever they took. If it's a toxic exposure, figure out how long they've been exposed to it. If it's an overdose, figure out how long ago they took the pills. Make sure you know when the pill bottle was filled and how many were in it, so you can count how many are missing. For unresponsive patients, it's just going to be a rapid head-to-toe exam, and we're going to have to look for those context clues or those history clues in the patient's house to figure out what may have actually happened, or you can get relatives or bystanders to help you out with what may have occurred. When we talk about treating tox or poison calls, decontamination is going to be paramount, because if the patient is contaminated with something that's harmful and you put them into your ambulance, not only is your ambulance going to be contaminated, but it could also hurt you. So if they have some kind of toxic exposure, you want to make sure you decontaminate them before putting them into your ambulance. And then figuring out the antidote. As we go through this presentation, you're going to learn about some specific antidotes for specific toxins, but in reality there aren't many. Most of the care for toxic ingestions and poisonings involve supportive care and getting them to the hospital as quickly as possible. We need to know what they were exposed to or what they took, where did they take it or how did they take it, when did it happen, how much did they take, and what is their body weight. A lot of the medicines we're going to talk through today have a lethal dose per body weight. Tylenol, for example, if you get over 150 milligrams per kilogram in your body of Tylenol, that is a lethal dose. As with any patient, maintaining a patent airway and good circulation is paramount. These patients a lot of times require RSI because their body is trying to reject whatever poison they have ingested, and they're going to start vomiting. If they're not awake enough to control their own airway, rapid sequence intubation may be indicated to control that airway and prevent aspiration. Providing supplemental oxygen is important if they need it, but we also know that oxygen can be a little bit harmful if they get too much of it in their body. So titrate your oxygen to 94 to 99%. IV fluids are never a bad thing. We know the solution to pollution is dilution. So if whatever bad thing is running around their bloodstream, we can put some fluids in there to help dilute it. That's never a bad thing. We should definitely consider cardiac monitoring, especially when you get into overdoses of cardiac meds and some antidepressants. There can be EKG changes. The coma cocktail shouldn't be used. Now, by the time I got into medicine, the coma cocktail was out. But for some older providers, the coma cocktail was very prevalent. Anybody that was unconscious got Narcan, thiamine, and D50. We definitely don't want to do that to these patients because depending on what they've ingested, the coma cocktail could be harmful. So now we're going to get into some specific toxins. We're going to talk about specific toxins and some of their antidotes and some of their treatments, but remember that the basic principles we just covered apply to all toxic ingestions. So the first one we're going to talk about is carbon monoxide, and I personally feel this is one of the most deadly to us as responders because we may not even know that we're in that environment. CO detectors are available for the home and commercial use, and I know some agencies that provide them to all their providers to either wear on their person or put on their first out bags, so they'll know if they're in a toxic environment or not. But it's an odorless, tasteless gas. You can't see it, you can't smell it. The only thing that happens is you start developing symptoms of being exposed to it. So it is very dangerous for us as providers. So carbon monoxide is the leading cause of poisoning for industrialized countries. Like I said, it's odorless and tasteless, and it's a byproduct of incomplete combustion of carbon-containing compounds. What that basically means is any of our fossil fuels, coal, gas, diesel fuel, kerosene, anything like that, are going to produce CO as they are burned. Most CO exposure is related to exogenous causes like any combustible item. A lot of times it happens in the wintertime when people turn on their heaters for the first time and something has happened over the summer and the ventilation is not right. So we see these CO calls pick up a lot as winter moves in. CO doesn't always have to come from combustible gases. Methylene chloride, it is converted to CO in the liver after it is inhaled. So it's an industrial solvent, not something you would have to worry about in the average home, but something you could be wary of if you have a lot of industrial plants in your response area. So how carbon monoxide works is that it competes for oxygen binding sites on the hemoglobin, and the hemoglobin like carbon monoxide a heck of a lot better than they do oxygen. Basically, if there's one hemoglobin and one oxygen molecule and one carbon monoxide molecule competing to bind to it, the carbon monoxide molecule is going to win. As the CO levels in the blood increase, oxygen molecules are displaced. The oxygen is released into the tissues, so people can become extremely hypoxic. Really, the only way to measure this is to do an arterial blood gas and get a carboxyhemoglobin level. People that smoke will usually have a small level of carbon monoxide in their blood anyway, but usually greater than 10% is indicative of acute carbon monoxide toxicity. Signs and symptoms include headache, dizziness, confusion, seizures, ultimately can be a coma. Long-term complications are that of any hypoxic brain syndrome, cognitive and psychiatric difficulties. They can have chest pains, hypotension, tachycardia, cardiac arrhythmias, myocardial ischemia, even VFib. Most deaths from CO poisoning are due to ventricular fibrillation from that hypoxic myocardium getting irritated and starting to fibrillate. With CO poisoning, the long-term complications can include multiple organ dysfunction syndrome, or MODS. That's where two or more organs become diseased and they fail to maintain their essential functions. Of course, with carbon monoxide poisoning, this would be because of hypoxia. When you get into MODS, the mortality rate is pretty high for those patients. People at risk for CO poisoning are the extremes of ages. So the very old and the very young, they have a harder time recovering from CO poisoning. People with heart disease who don't do well with hypoxic hearts anyway, pregnant women who are very oxygen dependent, and patients with decreased oxygen carrying capacity or chronic respiratory diseases like COPD. There is some technology out there to measure carbon monoxide levels or carboxyhemoglobin in the field. They're fairly expensive, but they do work. And so what studies have found is that in the lower levels, that 5 to 10, even 15%, they're hit or miss accurate. But once you get over that 15%, so if one of these is alarming like a 20 or 50% CO level, that's probably pretty accurate of what's going on with the patient. The treatment for CO poisoning is going to be based on their carboxyhemoglobin and their severity of symptoms. For any of these patients, the biggest thing is to administer high-flow O2 and even consider putting them on CPAP to force that high concentrations of oxygen down into their alveoli. Getting high concentrations of oxygen in the body and forcing out that CO is the best treatment. For truly severe cases of CO poisoning, hyperbaric oxygen therapy is going to be used. So they're basically going to put the patient in a large tube like this and lower their altitude so it decreases the pressure in which oxygen can diffuse into the blood. So it makes it easier to diffuse that oxygen in there and get out the carbon monoxide. So that hyperbaric oxygen therapy is indicated when they're either in a coma or have severely altered mental status with some neurological deficits. If they are pregnant, if their carboxyhemoglobin level is greater than 15%, or they have a history of loss of consciousness. It's less strongly considered if they have signs of cardiovascular compromise, metabolic acidosis, or they are extremely young or extremely old. One thing that people overlook a lot of the time is getting a CO level in the house if you have the ability to, or if the fire department has the ability to. You can monitor your SpO2 and your SpCO levels on most LifePak 15s now if they have that capability, but it's also important to get a reading in the house from where the CO is coming out of the source and figure out how much they were exposed to. Obviously, this is going to be a fire department job, not an EMS job, but the lethal dose 50, or the dose that kills 50% of the population almost instantaneously, is 2,200 parts per million. So if there's that much CO in the residence, that patient's going to be in very bad shape. But on the other hand, your permissible exposure limit, or the amount you're allowed to be exposed to by OSHA, is 50 parts per million. So certain levels of CO can be acceptable for certain time frames, but it's important to get a reading in the house if you have that ability, or the fire department has that ability to do it safely, and then you can report that to the hospital so they can better guide their treatment for this patient. So now we'll talk about cyanide. This is another colorless gas. It sometimes has a faint almond smell. A lot of people say you can't actually smell the smell of the almonds, but it is very toxic. It's used in the manufacturing process. Kind of looks like salt or white powder, but hydrogen cyanide is a product of combustion of plastics and modern materials with formaldehyde and things like that in them. So cyanide is produced when plastics, wool, silk, synthetic rubber, synthetic materials, polyurethane, or asphalt are burned. It's often encountered during structural firefighting. In fact, over 60% of the cases of cyanide poisoning in the United States are in firefighters. Toxicity varies by how much they've ingested or how much they've inhaled, and the concentration of the gas they inhaled. Signs and symptoms: burning sensation in the mouth or throat, headaches, confusion, hypertension, seizures and coma, pulmonary edema, and elevated serum lactate levels. Of course, the coma and the pulmonary edema are much later signs for much higher levels. Biggest treatment is to remove them from the source of exposure, prevent inhalation of the gas in the first place, so firefighters wearing their SCBAs. The standard treatment for cyanide poisoning is the Cyanide antidote kit and high flow oxygen. So here is the cyano kit. We are permitted to carry this on the ambulance in West Virginia. However, I don't know of anybody that actually is, because it's insanely expensive. I think everything you see there is about $1,800. So hydroxycobalamin is the antidote. We don't carry it anywhere around here that I know of, but most of the local hospitals do have 1 or 2 kits on hand in case they would see that type of case. Switching gears now, we're going to start talking about medications and different types of medications and how they affect the body when you overdose on them or ingest them accidentally. Cardiac medications are probably the most serious because all of them either change the heart rate or suppress the automaticity or do something with your vascular tone. So anytime cardiac medications are involved, the overdose can be very serious. So signs and symptoms for all these can range from nausea and vomiting to headaches to severe hypotension and cardiac arrhythmias, even getting into causing some heart blocks in severe overdoses. Severe bradycardia that occurs from taking too much cardiac medication can often not respond well to atropine, so external pacing is used. Some antidotes here: if they overdose on a calcium channel blocker, you should give them some calcium to overcome it. Glucagon is a well-accepted antidote for beta blocker overdose. There is a digoxin specific antidote, digibin, for dig overdoses. Glucagon is really the only one we have access to on the ambulance to fix a beta blocker overdose. The dose for that is 2 to 4 milligrams IV push. So exposure to hydrocarbons is fairly common. Anybody that mows grass or does yard work in the summer has probably spilled some gasoline on them at some point, or gotten it in their face. Toxicity is mainly from ingestion. Surface absorption and inhalation is really not an issue with these. It's important to note that less than 1% of these poisonings require physician intervention. Most of the time it's done by just washing off the substance. They used to say make them drink milk if they drank a bunch of gasoline, but they've ruled that out now. Mainly just gastric lavage can fix that. But you should contact your poison control center if you feel that your patient has gotten a large amount of gasoline on them or perhaps ingested some. Tricyclic antidepressants are often used to treat forms of depression and schizophrenia. They have a very narrow therapeutic index, so a small increase in the dose can quickly lead to toxic effects. May be responsible for more deaths due to intentional overdoses than any other medication. Probably a lot of that is due to when they prescribe this medication, they educate the patient on really how toxic it is. So if the patient goes to overdose, they know that it's definitely going to do some harm to them. So here we have a list of some tricyclic antidepressants. Probably the most that I have seen are amitriptyline and nortriptyline out there in the field, but there's a list of all the ones that you could see. Signs and symptoms when you need to worry about severe toxicity are confusion or hallucinations, respiratory depression, seizures, tachycardia, hypotension, hyperthermia, and cardiac dysrhythmias. As with anything else, going down through your primary assessment and managing your ABCs are very important. Sodium bicarbonate can be beneficial to tricyclic overdoses. Depending on what book you read, the dose range varies. I have seen some books that say you should mix an entire amp of it in 1,000 bag of normal saline and run that in over an hour. I have seen others that say you should bolus 1 to 2 milliequivalents per kilogram IV and then hang a drip of a bag mixed up. So depending on what book you read or what the doctor tells you is what you should do there for the sodium bicarb. So MAOIs are another one of those psych meds that have a very narrow therapeutic index and can be very toxic if overdosed on. They're used to treat depression and obsessive compulsive disorders. Here you have a list of common MAOIs. Signs and symptoms include headache, nausea, palpitations, tachycardia, hypertension, hyperthermia, and even in later stages, bradycardia, hypotension, and coma. So the problem with MAOIs is there's no known antidote for them. We're going to follow our standard tox procedures, treat the signs and symptoms, and take them to a hospital where they can get their stomach pumped and get treatment for these. So some newer antidepressants on the market, trazodone, Wellbutrin, some other SSRIs like Prozac and Zoloft. They prevent the reuptake of serotonin in the brain. The signs and symptoms of overdosing on these are usually fairly mild. They can range anywhere from drowsiness to tremors to nausea and vomiting and sinus tachycardia. Deaths are pretty rare. Usually deaths only occur when they're mixed with multiple other medications. Serotonin syndrome can occur with overdose of SSRIs. Basically, it's an excited delirium state, tachycardia, shivering, diaphoresis, hyperreflexia, and it can go into developing paranoia and excited delirium type symptoms. So we're going to switch gears again and talk about drugs that can be taken in an overdose that are available over the counter. We're going to start with salicylates like oil of wintergreen and aspirin. So signs and symptoms of salicylate poisoning include rapid respirations, hyperthermia, confusion, coma, cardiac failure and arrhythmias, abdominal pain, vomiting or vomiting of blood. Activated charcoal, this is one of the rare cases anymore where activated charcoal is a good drug and it definitely should be used. Generous IV fluids are also important. Acetaminophen or Tylenol is another one of those pills that's available over the counter that people have and will overdose on because it's readily available. It's only pretty deadly in large doses. If they don't take very much, then it's usually not too harmful to them. 150 mg per kg is toxic to the liver and will usually result in death. So if we have our standard average American male at 100 kilos, and they take extra strength pills that are 500 milligrams apiece, it takes 30 pills to get to that 150 milligrams per kilogram lethal dose. So the signs and symptoms for a Tylenol overdose go in stages. The stage 1, which we are most likely to see here, that 1.5 to 24 hours after the overdose, nausea, vomiting, weakness, and fatigue. The more serious signs and symptoms are going to develop later on down the road. The only known antidote is Mucomist. It has been proven to be highly effective in protecting the liver, but it's not something we give in the pre-hospital setting. That's something you're going to have to get at the hospital because it's technically an off-label use for Mucomist. So some other non-prescription medications, NSAIDs, non-steroidal anti-inflammatories. The signs and symptoms are fairly mild, from a headache to shortness of breath and wheezing. But these patients should be taken to the hospital and monitored just in case, as these are excreted either through the liver or the kidneys, so they need to watch their liver and kidney functions to make sure it's not going to hurt them long term. Okay, now we're going to talk about substance abuse and overdoses. As everybody knows, West Virginia is in the middle of an opioid crisis. We lead the nation in overdose deaths. We're about 4 times the national average. We also lead the nation in babies born addicted to drugs. So substance abuse and overdose is something that we're dealing with on a daily basis. But it doesn't always just have to be heroin, like is in the news so much right now. It could be alcohol, it could be stimulants, it could be cocaine, it could be barbiturates. There's really a number of things that people can become addicted to and then subsequently overdose on. So some other drugs that are frequently abused, cocaine. We don't see a whole lot of that around here because it's very expensive, but cocaine can cause problems, especially long-term. With long-term use, you see a lot of instances of very young people having MIs that use cocaine chronically because it's very hard on your heart. Hallucinogens, we've seen some of that recently with the synthetics, the synthetic marijuanas, the K2s, the Flocka is a new one now, where they will hallucinate very violently and end up in that excited delirium state. So the physiological effects of some of these, alcohol is a CNS depressant, but long-term use can cause a host of health problems, including liver and heart disease. In cold conditions, it can cause you to dilate your blood vessels and lose heat. So people can become very hypothermic when they drink a lot. That comes into play a lot in the fall during our college football games when people drink a lot and are out in the cold. Ethylene, of course, can cause a bunch of problems. That's one of the byproducts of making moonshine. If you don't make it correctly, you can end up with ethylene or methanol in your moonshine, neither of which are good for you. As you can see here, the consequences of alcohol abuse long-term are very bad for you. Liver disease, liver cirrhosis, things like that. Withdrawal syndrome from anything can be sometimes fatal, but it can also have very serious signs. It can range from simple mood swings and vomiting all the way up to seizures and unconsciousness and even MIs. So we're going to switch gears again here and talk about bites and stings, injected toxins. These are fairly common calls that we get as providers for bee stings or snake bites. So people can die from allergic reactions to stings of insects and bites from insects. Honeybees will leave their stinger inside the victim to release poison over a longer period of time. Wasps and yellow jackets and hornets, they'll sting until they remove themselves from the contact, but their stinger won't stay in place. So bites and stings can range anywhere from localized pain and redness all the way up to hives all over the body, tachycardia, hypotension, and full-blown anaphylaxis. Simple treatment for bee stings, you just want to wash the area and gently remove the stinger if you can by scraping it out with the corner of a credit card or something, as long as you can do it without squeezing the venom sac. Cool compresses are also fine, and observe and treat for signs of an allergic reaction like redness spreading outward from the site or things like that. So moving on to bites, the brown recluse spider is a spider that we do have around here that can inject a very painful sting and cause a sting reaction. It lives in dark, dry locations, and it has, that you'll note here, that little spot on its back that lets you know that it is in fact a brown recluse spider. So the bite of a brown recluse is usually painless, but then the swelling starts to spread. Within 8 hours, you're going to have pain and tenderness, and then tissue necrosis will occur over the next few days to weeks. You can also get fever with chills, nausea and vomiting, joint pain, and even bleeding disorders from the toxin of a brown recluse. Here's an example of a 4-day-old brown recluse spider bite. You note the sting is here, but the tissue redness is extending, and this is what happens over days to weeks. The infection and necrosis spreads out from the site of the bite. So on the same topic of bites, we're now going to talk about snake bites. Their signs and symptoms depend on the snake and the location of the bite and the amount of the venom injected. Some older snakes don't inject a lot of venom, while younger baby snakes tend to inject a whole lot more venom. They don't really have much control over the amount of venom they inject, so they say that a bite from a baby snake is much worse than a bite from an older snake. Common snakes, pit vipers, cottonmouths, rattlesnakes, and copperheads. Really the only ones we have to worry about here in West Virginia are rattlesnakes and copperheads, with rattlesnakes really only being found at higher altitudes, places like Cooper's Rock and things like that. So this is a picture of a cottonmouth. Again, this is not a snake you would find around here. They like much more humid, wet climates, like in the southern part of the United States. This is a picture of a diamondback rattlesnake. Note the head here, how it's shaped in kind of that diamond formation. That's indicative of most poisonous snakes, and the rattler here on its tail. And you can note here, this is a copperhead. This is a snake that is found commonly in West Virginia. Note the copper coloring of its head, hence its name, and the shape of its head, again, that diamond shaped, that lets you know that it is most likely a poisonous snake. A couple things about snake bites: you should never capture a live snake and try and bring it to the ER. That has happened, and we definitely don't want to see that happening, so don't bring anything live to the ER. With rattlesnakes and copperheads, the antidote is crofab. They do keep those at most of the local hospitals in case there would be a snake bite come in. The problem is it takes multiple doses sometimes to actually fix the problem. So a lot of times we will end up taking these patients to tertiary care centers like Ruby or Charleston, where they have stockpiles of this crofab antivenin. Now we're going to talk about poisonings caused by weapons of mass destruction. So we're going to talk down through CBRNE, chemical, biological, radiological, nuclear, and explosives. These are the types of WMDs that can deliver potential toxins or poisons to people. The C in CBRNE stands for chemical agents. Chemical agents can be fairly common, like riot control gas or tear gas that police officers use for riots or for barricaded suspects. Riot control gas or tear gas is easily decontaminated with soap and water. Some chemical agents are highly dangerous and deadly, like VX, poison gas, sarin gas, or GB. They've used sarin gas in the Middle East. Saddam used it before he was removed from power. Very powerful nerve gas. That's an atropine 2-PAM kit there as the antidote for that. But the problem with that is it may take several doses. So the ones we were carrying on the ambulance for a while might not have been effective had you received a large dose of the nerve gas. So the B in CBRNE stands for biological agents. Biological agents are pretty scary when you think about it. If you think back to 1918, the Spanish flu killed 1 in 3 people in the country, so that was a biological agent. Obviously it wasn't weaponized, but now we have to worry about and think about with terrorism people weaponizing biologic agents. So in 2002 we had the anthrax letters all across DC. We saw guys in hazmat suits going up the steps of the Capitol on the news. Fortunately, most of them were only white powder. Very few of them were actually anthrax. They did some things to combat this to help us as first responders. Any mail that's going through a federal facility is now radiated, so anything that was alive inside of it would be killed. There are now mass decon protocols in place for federal buildings, so if something were to happen, it would be easier to decon everybody. With biological agents, the big thing you have to worry about is what were you exposed to and for how long. The treatment for these things are going to be figured out by the hospital. Our role is simply going to be to transport them there and give supportive care. So radiological and nuclear, there's a difference between the two actually. When you talk about CBRNE, the R is radiological, and that just stands for radiological material. Gamma and alpha rays that you would see like in medical radiation. That's a lot different from weapons grade radiation. The big thing we worry about with radiologic substances is dirty bombs. Terrorists have in the past tried to put radiation sources inside of a bomb and blow it up and disperse it. That is a dirty bomb, but most of those have been highly ineffective due to the nature of available radiation sources. Basically, if you take an alpha source or an X-ray source that you would use in an X-ray machine and blow it up, it just disperses and goes into the air. It's not really going to do a whole lot to hang around and linger and actually make people sick like the goal would be. So those dirty bombs are fairly ineffective. And nuclear events are unlikely. And nuclear events obviously are using the use of weapons grade radiological material to split an atom and create a big event like that, but fairly unlikely given the nature of those devices. So the last letter of CBRNE is E for explosives. That stands for improvised explosive devices. They can be used to disperse a toxin depending on how it was made. The scary thing about these is they can be made with household items. The Boston Marathon bombers used fireworks and pressure cookers to make fairly destructive bombs. So with a little bit of knowledge that's available on the internet, anybody can go and make an explosive device. So thank you for watching. We hope you enjoyed this presentation on poisonings and toxins. Please visit our Pierpont EMS YouTube page for more helpful educational videos.